Hello, everyone. Welcome. My name is Seth Feuerstein. Thank you for joining us. I can say without hesitation, it is an honor to be here today with three of our nation's leaders in their various fields. And so it's really a pleasure to have them here. By way of background, I've been a member in one form or another for the last 20 years of the faculty in the Department of Psychiatry at the Yale University School of Medicine, but I've spent a lot of my time working on leveraging technology to improve access and quality of mental health care, both in the nonprofit and for-profit sectors in the United States. And I have the pleasure of moderating a discussion today. I'd like to ask our three esteemed panelists to give a little bit of background about themselves before diving into the order of the program and content. So I guess on my screen in clockwise order, first, Dr. Torrey Creed.
Hi, happy to introduce myself. Hello, everybody. Torrey Creed. I am an associate professor at the University of Pennsylvania, licensed clinical psychologist and implementation scientist, which are some lenses that I'll bring to the conversation today. And I've had the pleasure of working with the Lyssn team for a number of years now. I'm a senior consultant supporting the implementation work that they do. Very excited for the conversation today.
And on my screen, next in clockwise order is Ashley Newton.
Hi, everyone. It's wonderful to be joining you today as well. I am the CEO for Centerstone's Institute. I've been with the organization for 18 years, and I've had the good fortune of doing a lot of different kinds of jobs over that period of time. So I spent about 10 years in our clinical operations and have been a direct service provider. I've also helped to grow new programs and to move into communities that were in need of new services. And then for the last 8 years, I've worked in the Institute. And most of my background is really in the quality and patient safety space. Glad to be joining you all today.
Ashley, do you mind telling us a little bit more about Centerstone? Because while it's quite well known and quite large, some people here may not be familiar with it. If you could share a little bit more about the whole organization, that'd be great.
Yeah, I'd be glad to. So we are a not-for-profit behavioral health organization, primarily located in the Southeast. We have a little over 200 brick and mortar facilities, and we are primarily located in Illinois, Indiana, Florida, and Tennessee. We also have a clinic in North Carolina, and then we have a national network service model that caters to military service members and their families. And we have about 2,000 contracted providers who work as part of that model. We serve people of all ages, from birth to death, with a range of different mental health needs and substance use needs. And we operate a number of different kinds of programs. So everything from inpatient, hospital, residential services, to outpatient community-based services, typical kinds of medication management, psychiatric services, and then things like IDD and foster care services as well.
Excellent. Thank you so much for indulging us in that. And Dave Atkins, you're last.
Awesome. It's great to be here, and it's my great pleasure to get to work with all of these fine folks. I'm a clinical psychologist by background. I was a professor in the psychiatry department at the University of Washington for a number of years. I'm the CEO and co-founder of Lyssn. And in behavioral health care, so much of treatment is a conversation, whether we call that therapy or counseling or peer support or care coordination or coaching, medication management. Conversations are central to all of those. And because of that, that treatment is really hard to measure. And we have historically relied on humans who have been trained in well-validated clinical systems. But the reality is we would record sessions and share them with people like Torrey. And Ashley's done some of this work as well, and I have. And we would take the long amount of time to make individual judgments about the quality of cognitive behavioral therapy, as one example, or motivational interviewing. And so what became Lyssn really started with the idea of there's got to be a way that we could develop technologies to automate that process. And then if we could do that, then we could automatically generate performance-based feedback to support training. We could automatically provide quality feedback to enable precision supervision, so that a supervisor is actually looking at actual quantitative data as they're meeting with their supervisee, and be able to look at both highlights and areas that are challenging. And quality managers could have a big, broad picture of the quality within the organization. So that's what started within the universities and has become Lyssn, and it is really our pleasure to get to work with great folks like the people on this panel, as well as fantastic organizations like Centerstone, in thinking through how can these AI tools really support training, practice, quality assurance, and supervision at scale in ways that were not possible historically. So great to be here.
Yeah, and I will say I've started getting familiar with Dave and his team's work. Actually knew Torrey already, and also met Ashley over the last few years. It's been, phenomenal to learn about your work, Dave. And obviously, there's a dog in your household who also finds it exciting and was, piping up as you were describing it. So it's obviously
Sorry about that.
universal. No, it's great. So the way we're going to run this to try to have some order before the chaos is. We'll talk about some of the ways you're collaborating with the others in this discussion. You can sort of participate with each of them. Questions will certainly arise among people who are here today, and we'll ask this meeting platform is one that you may or may not be familiar with. You'll notice at the top there are two different little things that look like chats. One of them has a question mark, the other one does not. We'll try to consolidate questions in the area where there is no question mark. It's a chat function area. We'll still get to you if you put it in the question mark one, but we're hoping everyone just uses the chat area where the number one is currently. And then at the end, we'll go through the questions and we'll kick it off now with Torrey. Torrey, if you can provide a little bit more context about training in general from your perspective, feedback from your perspective at various points in someone's training, and other things that come to mind in the work you've done collaborating with Dave and others in this area, that'd be really great.
I would love to do that. The things I'm going to talk about are going to really build off of Dave's introduction here about what this work is. If folks will humor me, I think I might actually start from maybe a slightly unexpected place. I want to talk about actually something that is the opposite of the role of artificial intelligence in scaling up psychotherapy. I want to start by telling people actually about the first client that I ever worked with, but I promise it's in service of the conversation. When I was in my first year of a master's program, I took classes that covered lots of different psychotherapy approaches. There were lots of different models. We talked about them in depth. I did pretty well on the tests. I got to year 2, where I was assigned my first client in my practicum. It was a teenage boy who'd lived through some really horrible things. And when I sat down across the table from him, I realized I had no idea how to take the things that I had learned in all of those lectures and use them in any way to help this young man move toward the life that he wanted to live. I literally remember feeling unprepared to take anything that I learned in that class and actually use it in a way that was going to connect with this boy and his life. And I think, honestly, there's a moment where any new clinician sits across from that first client and wants to sort of look over their shoulder and say, like, me, this person is looking for help, and what they got was me. I did my best in that moment, and I remember really clearly afterwards going to my supervisor to talk about what I remembered from that session. He reassured me that I'd done okay, and we role-played a bunch of stuff that I could try in the next session. And from there forward, I had 60 minutes of supervision each week to try to be ready for 30 clinical hours a week of working with clients. And even when I got support from him and I role-played things in meetings with him, my clients never said what my supervisor said in the role play, and I had no idea whether I was actually doing it right in the session. Graduated, I worked in the field, I went back for a PhD in CBT, and even with that more defined skill set that I was trying to learn, I had that same similar experience with the first time that I sat down across from a client to try to use my new skills. And the issue was that there is no way to do a trial run with a client, with a real person who's looking for care. And I think that that is probably relatable for anybody in the room who has seen a first client, where whether that is your first client ever or your first client with a new skill, there is this incredible leap going from a role play where you're practicing new skills to actually sitting in a room with a human being who's looking for help and hoping like hell that you're getting it right and not having a good way to know. When I introduced myself, I was saying I'm also an implementation scientist. So at this point, I like to think about those kinds of questions at scale. So I'm really interested in thinking about how to move the needle broadly to improve care and quality of care in large systems. It's something that all of us on the panel here today have in common, is trying to figure out ways to make sure that more people have access to treatments that work. And in 2 decades of doing that work, the rate limiting factor that I have always run into, and Dave named this right off the bat, it's been an issue of human power. It really used to be that the only way to make sure that therapists were learning and using any of these evidence-based psychotherapy skills was to have experts literally sit down and listen to a session recording, rate it for fidelity, write up feedback. And that is a process that is very slow, it is very expensive, and it can take a couple of weeks for there to be turnaround. And we all know that that is not actually the best way for anybody to learn a complex skill, is to get very spaced out and not timely feedback about how they're doing. And it's not a way to then be able to plan treatment to integrate where to go with any of that feedback. By the time you get the feedback, therapy has moved on. And yet it was the best that my team could do, and most clinicians don't even have access to that. So I guess I want to launch the conversation here today by saying, what if instead, as a therapist, starting in that zoomed in version of this, what if you could practice with a set of diverse, challenging clients and get instant feedback on how skillful you had been in actually responding to them? And doing that in a way where you're not only practicing until you know you're doing it well, but where you then have extra space to be able to try out lots of different ways of developing that skill until you feel, as the therapist, really comfortable with what you're doing. And if you had an opportunity to practice that way with immediate regular feedback until you felt ready to then bring that skill into a session with a real person who's actually seeking help. And then imagine scaling that up another level so that we're thinking about mental health systems where we can use those kind of tools to quickly train up new staff as they're being onboarded, build advanced skills in the seasoned staff that we have, try out new approaches to see if they're still in line with treatment fidelity, and then be able to really think about how those skills that clinicians are learning how that's translating into the actual therapy room. So for me, what's been really revolutionary in the work that we've been thinking about is how AI can really offer those solutions for immediate feedback that people need to be able to learn these kinds of complex skills at a scale that allows large mental health systems to be able to invest in their workforce to take quality of care to a really high level. And so working with Lyssn, we've partnered with treatment developers and internationally recognized training experts to create training tools that really focus in that very specific way, including feedback around treatments that work. Training tools have subject matter experts and where they're really distilling core skills in videos and written didactic content, dialogue examples. And honestly, that piece is what we've all come to expect already from high quality training. And it is where many other learning opportunities stop. So the Lyssn tools then go on to offer video vignettes of these, as I said, challenging, diverse client presentations that essentially feel like being in a telehealth session. The learner has the opportunity to respond to each client by demonstrating the skill that they're learning and then getting instant feedback on how skillfully they did that thing. As a therapist, it gives me the opportunity to practice a skill until I'm on target And then I can play around with other ways of trying to respond to those clients or frame things a little bit differently so that therapists really have a place and space and feedback to find their therapeutic style within fidelity to these tools that we know work. And what it really does for me is it connects the dots between learning what to do and knowing when we've done it. And maybe one last thing I want to say as I'm thinking about how these tools really come together for me, I think the real question is ultimately about impact, right? We want to know that not only therapists can deliver these skills, but we want to know that they do deliver these skills in session. So Lyssn also has a QI platform that provides therapists with immediate feedback about what's happening in their actual sessions, including, as Dave was saying, how skillfully they're delivering things like CBT and motivational interviewing and other more general clinical skills. And the Lyssn team has really thought about how to make that information actionable and practical. So the platform includes tools to make supervision efficient, like searchable transcripts and audio and video, things that I like to call virtual sticky notes that allow supervisors and therapists to essentially tag sections of sessions with comments to be able to chat between supervision sessions, and it even drafts a clinical note. So then when we with these kinds of tools, get the opportunity for what we think about as essentially a virtuous cycle. Therapists are getting confident with new skills that they're learning outside of their session. They see those skills show up in their actual sessions, and then they can return to the training tools to fine-tune their delivery in the training platform in a way where the rinse and repeat of that ultimately drives excellent care. And then pulling all those pieces together at an organizational level, those metrics are available and aggregated in a way where supervisors and administrators can have a data-driven peek into what's actually happening in those sessions. You can see areas of strength in your clinic or your service line. You can identify places where you might want to lean into emphasizing a specific training tool during onboarding or in your regular training cycles. You can demonstrate to a payer that you're really delivering high quality care. There's a lot to talk about with these tools. I feel like that was a lot of information at once. And I think that hearing about what that looks like in action can really bring it to life. I wonder if I might hand things to Ashley Newton to talk a little bit about the experience that Centerstone has had integrating these kind of training tools in their system, if that feels okay as a transition.
Yeah, absolutely. I mean, Ashley, you bring really an interesting perspective. The scale of Centerstone that you mentioned, I've always known it as a large organization. It obviously spans many states, several states. You've spent time training at MIT, you've studied Six Sigma, like you have this very unique perspective on things like how to roll something out, implementation, what has to be considered. So yeah, absolutely. That's a great transition. Thank you, Torrey.
Thank you. And gosh, Tori, so much of your story is relatable. And I kind of laugh to myself because sometimes the simplest questions are the most challenging for me to answer. So when Seth says, introduce yourself and talk about your background, like so many people in community mental health, we wear a lot of hats. And I don't know for folks joining us today, if you've spent time in community mental health or if you care about someone who's in a community mental health, you may know that. But I mentioned that I was a direct service provider because I think for me, that's part of my experience that I really value. And it has forever changed the way I think about the way we can support people doing that work. It is incredibly difficult. And, Tori, you talked a little bit about that experience for you and how it ties into this. And, when I came into this field, my first job was as a children's case manager. I was someone who had a bachelor's degree at the time, and like many, many other people, went back to graduate school and continued my education while working. But I was someone who maybe in some ways was amongst the least prepared to work with a group of people who had really high needs. And I remember the first time I showed up at someone's home, away from my support team, my peers, my supervisor, and the first time I encountered someone who was thinking about suicide and how terrified I was that I was going to get it wrong in the moment, and just trying to recall everything I had been taught before that. And I think I was like 24 years old. So These experiences are so real, but people face them all the time. And so now today, when I think about that, and of course now I have this this experience that I get to carry with me in these different areas of training. And Seth, you mentioned getting to spend time learning different techniques or design techniques that we can think about and kind of bring into this work that really help. I think all of those things to me kind of create this golden thread through what I feel have experienced as like this zigzag kind of career pattern, but it's led to this place of being able to think about how do you take those and do something meaningful with them that help the people around you to make the job easier to do hard work well. And I think that, technology is one of those things that we can leverage to do that. And so when I think about, training, that to me is we can leverage technology and training approaches that make it easier to do hard work well and to get the job done right and to really support clinicians in that work, because we all come into this space wanting to help others. And so I think we can really build tools and processes and workflows that support staff in being able to do that. And so I feel like that's not only an opportunity, there's not really an obligation, more of a responsibility. If you are someone who is working as part of a system and you get to design that system, then that's a really exciting thing, but there's also a lot of responsibility in that. And so it's something that we take seriously. And that's something that I really value about Centerstone. We've got about 4,000 staff who work across all of these different kinds of settings. And so when I think about the needs of the system, the diversity of the workspaces and the different kinds of people that we work with and the different needs that they have, our training needs also reflect that. And so we have to think pretty broadly about how do you really, at scale, to Torrey's point, how do you support a large staff of people who need different things? And so, we obviously have been training for a long time. That's not new to Centerstone, but we've tried a lot of different approaches. And so, we started down this path of thinking about simulation and really dipping a toe in the water, I would say a little over 4 years ago, early 2020, so almost 5 years ago. And so we actually started that thinking more about using live actors and doing it on a much smaller scale. And I would say that parts of that experience worked well for us in terms of the training outcomes and getting people to engage in learning about evidence-based practices, giving them opportunities to get feedback that was personalized and they could get that feedback more quickly. Where things got really challenging was how do you do that with a larger group of people and across a large system? And I hear that frequently when you talk with other folks about that particular training approach. And so, that really has shifted the way that we think about this to not only how do we take what we know from research that makes training really effective and really work and take the feedback too from learners to say, here's how you create a really positive learning experience for them, but to do that in a way that we know can be achieved at scale across a system. And so I think that's really where we see the value in having kind of this approach and this hybrid strategy around let's take those lessons and let's bring technology in that helps us to accomplish that. And so that's really what led to this partnership that we have with Lyssn, and really gave us a more robust training strategy as an organization. And so if you fast forward, we're about 1.5 years, I think, into our relationship, working with Lyssn to implement this training platform. And that's been really exciting for our organization. And so we still offer simulation in different forms, but we really are thinking differently about how do we think about the trainings and the different evidence-based practices that we want to make available and which way of training is most appropriate. And so if there's an evidence-based practice that we think everybody really needs because this applies so widely to our clinicians or to the people that entrust us with their care, we really think that having a technology-based solution is going to give us the greatest chance of success and to getting that into the hands of our staff in a way that they can use it in day-to-day practice. And that really is our goal. Again, making hard work easier, but also doing that in a way that learners value the experience and feel like they leave right away with something that they can use. So we have been working with our clinical operations teams and then using the wisdom of the Lyssn team to bring in that kind of implementation science lens to think about how do we borrow lessons from research and from science to help guide our efforts? And I think that approach, and we have internal to Centerstone a team of people with a lot of background around project management and change management. But I think getting to put all of those folks at the table together means that you get to bring all of those minds together to come up with a plan that's really tailored for the organization. And so that's been a really great experience for us. So now we are hearing things back from our staff about the experience that they're having, which has been overwhelmingly positive for us. We're thinking about how do we, again, implement things at scale. So how do we make sure that it's easy to get to the training, that it's easy for folks to access that we're trying to knock down the barriers that you might typically hear about, like how do you create time for training in the day? How do we make sure that it's accessible? If I only have 15 or 20 minutes, how do we create trainings that you can access in that time and realistically do something meaningful with, where you don't feel like you're having to totally start over every time you go back? And so, one thing that we have really appreciated about the approach that Lyssn takes is that so much of the way that the platform is built and the trainings are built map on really well to the way that we also think about training. And I think it's because the underpinnings of the way that the system is built really go back to research around how do you build trainings that we know are more effective and that are more likely to result in behavior change. And so I think there's a lot of alignment there in the way that we think about tools and trainings and how we build those. And that has really given us a strong foundation in terms of the way that we can partner and come together to really roll those out across the organization. So that I could talk a lot. This is one of my favorite things to talk about. So I could talk for a lot longer, but we have been utilizing simulation training for almost 5 years now. We have hybrid strategies where we can offer that in several different ways. But I think that really bringing the Lyssn team and the product into our strategy is what has solved kind of the challenge for us of having a strategy that really is scalable across an organization with, like I said, more than 200 sites, about 4,000 staff. And we want to make sure that as our company continues to grow, that we have a strategy that can grow with it. So
That's awesome. Thank you. Yeah, it's funny. I think Torrey knows this. I don't know if Ashley does, but I first met Dave and his team. I have a program grant, or had for a long time, a program grant at Yale to work with NIH-funded researchers on kind of how to take their research and help bring it out into the broader ecosystem. And when I first heard about the software from one of his colleagues, it like, people listening hear all these things it does and how well it does. I'm like, I actually didn't believe it. Like I had to spend more time with them. I'm like, this is 3.5 years ago. I was like, this can't be. Like this is not possible. And it turns out, the NIH gave them a lot of money over the years, and they really, and they've, Dave, you've published probably 50, 100 papers at this point in really great journals on the work. And interestingly, that transparency, I think, through that, a lot of that work came like a practicality almost in all the different projects you did, but also you've worked across organizations with, dozens of employees, hundreds of employees, as Ashley pointed out, thousands of employees, and without getting into confidentiality, like now you're working with organizations that have, say, more than 100,000 employees, which is true at this point. So can you talk a little bit about sort of what you've learned about implementing with different sized partners? And you've got note-taking tools, you've got quality tools, you've got training tools, like all of which is derived from the core work that you and your team have done. Can you talk a little bit about that, like the differences between those types, the size and the types of customers that you work with and partners?
Yeah, absolutely. Maybe just in starting, AI can feel a little magical, and people, wonder like, oh, is AI coming to replace therapists? And we continue, like, as a clinical psychologist, like, I think that there is something incredibly special and powerful about the ability for humans to connect with and help other humans. And really, as we have thought about this, initial phase of work at Lyssn, this idea of augmented intelligence, how is it that AI can kind of scaffold, support, and enhance clinicians in whatever way, shape, or form? I mean, when you sit back and reflect a little bit on not just therapy and counseling, but the different types of conversations that are health and well-being focused in some way, collaborative, empathic, goal-oriented conversations, you realize they're everywhere. And it's not just in psychotherapy by a psychologist. It is crisis call takers, it is care coordinators, it's peer supporters, health coaches. And so, we've had the pleasure of working not only with organizations of different sizes, but also of, really fundamentally different parts of our kind of health and well-being ecosystem, if I can use that phrase. And the core thing that we've really been thinking about is, if we could do, how do we want to train people, and how do we want to do supervision, if we didn't have the rate limiting factors of humans reviewing all these sessions. And so that's the place that we started from. We thought pretty carefully about some of the basic science in terms of learning sciences. And when you look at that, I'm going to say something that's just obvious to all of us, but the really key thing about learning new skills is practice and feedback. So yes, we should get good, didactic content from experts in the field like Dr. Torrey Creed. And we should watch examples, but too often that's where, especially our post-licensure training, that's where it ends. It ends up being pretty passive. And so sometimes I will maybe slightly snarkily say that, it's like wanting to watch Wimbledon and think you're going to learn how to play tennis that way. You can learn a lot about the game, but we actually have to practice. And the other thing that is interesting and informs our approach to training is something that Ashley alluded to, which is historically when we've done training, again, especially post-licensure training, it has been the half-day workshop. It is this kind of massed one at one time. And we know, of course, in reality, with all sorts of other skills, like that's not how you learn. You gotta go play, but you don't have to necessarily practice a lot each week. But the idea that, if you want to become a good tennis player, that you're going to go practice your backhand for maybe even 10 or 15 minutes. And so some of that thinking, I'm just trying to kind of provide some of the intuition and kind of the concepts behind how we thought about developing tools, and particularly the training tools, where they're really designed, they do have some didactic content, but they also really support you jumping in and for 10 minutes practicing empathic reflective listening and getting feedback on that as one example. And so, as we think about working with different organizations, the great thing about AI software and cloud-based software is that it is always available and on demand. And the basics of the training software in particular are really straightforward. It is being able to log into a website and decide which training you want to work with. And as soon as you spend a little bit of time, you can quickly jump in and start practicing. And that is the goal. And so, what we have found, both working with Torrey and thinking about implementation, and with Ashley specifically at Centerstone, there are certainly differences when we're working with a single clinic versus a large organization. But it's really, it's not so much around the implementation of the software itself. It's really understanding the workflows and different service lines. So that's something that we've talked quite a bit with Ashley about at Centerstone, or who are the different providers? Because it's not, in a large comprehensive behavioral health organization, there are a lot of different flavors of intervention. Again, all the way from kind of peer supporters, substance use counselors who may or may not be licensed, all the way up through psychologists and psychiatrists providing more specialized care. And all of them can benefit from this same basic idea of practice and feedback around specific skills.
Even psychiatrists need
even psychiatrists. I know it's hard to imagine, but when you're handing out the pills, that way that conversation happens matters.
Yeah,
Yeah.
I love that analogy that you gave about uh, tennis, because it's interesting. Even when you think about the number one players in the world, and an event like Wimbledon, it's really an interesting analogy. Like their coach is actually at the matches. Like they are constantly being observed by their coaches. They have the luxury of essentially a lot of capital and a lot of effort going around them with live humans. But even in sports like that, the coach is always there. The coach is always providing feedback. And when they're not doing well, they often change coaches. Even the number one, number two, number three players in the world. So I think it's a really fabulous analogy.
One of the other things that maybe I'll just mention at this point is I think like AI is having a certain moment right now in our culture, and so I think has been some consciousness raising about the possibilities of AI, and I think and that is exciting and good, and but I think we are quickly realizing that AI needs to have support. We need to understand what is foundationally, what's the reliability and validity of AI, and then very importantly, what how do we understand ethical AI, and you know, kind of just to hit on those themes and how we think about them at Lyssn. The founders are scientists turned entrepreneurs, and so we come from a rigorous research-based perspective, and so Seth mentioned that we have published many, many different peer-reviewed publications, and transparency is really the key thing, right? Both in terms of validity, reliability, and also ethical AI. And so, we continue to do research and we continue to make sure that we can convince ourselves as well as convince our potential customers that the AI is valid and reliable. Earlier this year, we published a collaboration with colleagues at Talkspace, and we that paper's in JAMA Open Network. We analyzed, Lyssn's AI analyzed over 20 million conversations on Talkspace's platform, from more than 167,000 clients, 5,000 providers. And so those conversations get analyzed by Lyssn's AI, and then we get these different quality metrics on the far side of that. And then we could use those to look at how well Lyssn's AI predicted client outcomes, things like did you drop out of treatment? How were you satisfied with services? And how quickly did you improve in depression symptoms? And we could show that, yeah, various dimensions of AI and exactly what of our quality metrics from AI and exactly some of the things that we would hope, things like being an empathic, collaborative provider, having a good goal-oriented conversation within that collaborative in a relationship. Those things predicted those good outcomes. But point being, it's one of the ways that we try to put certain stakes in the sand for ourselves as well as our customers. And it's like we are continually trying to push and demonstrate that the AI is valid and is clinically validated. The one other thing I will
You know,
say,
and
and just one last thing, is we have also a yearly report on potential AI bias. We want to make sure that the type of feedback that we provide to all of the diverse providers in providing care in the U.S. behavioral health care system is that it's equally accurate and it doesn't depend on your demographics. And so that's something that we update yearly as a part of our commitment for ethical AI.
yeah, that's actually what I was going to ask about. We have, I would say pretty reasonable diversity of gender on this call, but not necessarily diversity in other ways in terms of how we look visually. And so that was actually the question I was going to ask about, because obviously Torrey and Ashley, the organizations you work in are incredibly diverse and the people you serve are incredibly diverse. So I know that's important to both of you. And that was what I was going to ask you about, Dave. I know you've published many papers on that, and I've done a lot of research on that. So you beat me to it, unfortunately. Um, I We have a couple questions. We have a few actually. I think, well, first, Tori, Ashley, any thoughts or comments on some of the things that Dave talked about?
Just to voice support for the kinds of things you're talking about, and to say there's a parallel within the provider organizations. And so as we have thought about implementing AI within our training strategy, we actually as an organization are implementing AI in a larger kind of way as part of the strategy of making hard work easier. And so we're using AI to help with things like note taking, is a pretty common example. I hear a lot of organizations talk about that. And so we are also thinking about things around, how do you use AI in ways that are ethical and responsible? And what do those behaviors look like? How do we behave in ways that are consistent with that as a goal? And so, I would say if you're, working as part of an organization who's thinking about that, for us, that meant things like how do you really start to institutionalize that? And how do we really think about transparency, right? And what does that behavior look like? And so we've done a lot around communication with staff, education with staff about what we will do, what we won't do, what this means, what kind of AI we're using. We do have an AI policy and a governance structure. So there are some different things that as an organization that we're learning that we need to do as we shepherd this through the system. And for us, kind of all of those things go hand in hand. And so, I think those are the other important pieces. It's not just the here's this thing that technology can really help us with, and that is a huge, very real opportunity I think that we all have. But there is also this kind of obligation, I believe, around how do we do this in ways that are appropriate and ethical and responsible, and to ensure that we're using it just in ways that are appropriate and helpful, and that we're avoiding unintentional harm in places. And so I think the example Dave gave is a really good one in terms of something we might look for in a partner to say, what are you doing, to kind of shore up your piece of the puzzle? But there are additional steps that we would be taking as a provider organization to do our part as well. So all of it's part of the same conversation for us.
And maybe to piggyback off of that, one of the things that I have just really enjoyed and valued in the partnership with Centerstone is both that big picture perspective that Ashley is describing about how to think about this from an ethical perspective in a do no harm place, and also partnership around these just really practical questions. Goes back to what you were saying before, Ashley, about like making hard work easier. Similarly, bringing in an AI-based tool, I wish that that were the simple solution and it was just, here, let's plug this in and now problem solved. And it's a complex, important thing to think about. And so I think just a piece I think I would underscore is around partnership between folks who are building these tools and folks where the hope is that the tools are being used, and that really needs to be a bi-directional conversation. And that is the thing that I've really valued in this work, is that your team has really gotten down into the weeds of thinking really systematically about and strategically about where are the right places within this organization for us to start. For example, intuitively, I think some groups might say, gosh, this particular clinic's really struggling with care, let's start there. And instead of being tempted and pulled in that direction, it's let's think about where we could find some early folks who want to be trailblazers and try this and are excited about it, and then have them really be the folks who are talking to other people within our system about their experiences. There isn't a one-size-fits-all approach to implementing these kind of tools, and the willingness and excitement and rigor that Centerstone has thought about this from, I think, has just been a really powerful piece.
That's really interesting. I think we have a great question actually that came in that I think illustrates some of the potential for confusion and misunderstanding when you say AI, when anyone says AI, because there's so much discussion about AI in the media. There are so many different consumer tools that people are playing with. And there's this, both reality and non-reality sort of fantasy of all the different things AI can do and will do one day. So really, really interesting question came in about AI tools and what they can do from I'd say more of an efficiency perspective. You've obviously discussed automated note tools. So the question that came in is, can AI tools be instructed or programmed to enter information automatically into an EHR from verbally recorded sessions between the client and the provider? For instance, if an AI tool can populate fields such as gender or income level on an intake form, then that data would never be missed or inaccurate in the EHR. I happen to know the answer to this, but I think it's a great sort of question because it's actually an interesting question, but also because it illustrates some of the different ways people think about using AI tools. Do you want to try to tackle that, Dave?
Yeah, happy to. So I mean, I think the really critical thing is how AI gets trained. And if it seems sort of magical that AI could evaluate how empathic you are in your communication, it's not that the AI understands anything about empathy per se, but we train it. We use well-validated clinical tools. We then provided many, many training examples. And so like Torrey and her team has done this work historically with CBT and CBT fidelity. But when you give AI lots of examples, like here's a recording of the session, and then here's an expert human judgment that said that was a very high empathy session, or here's a different example, it's a very low empathy session, then what is powerful about the AI is that it can begin to do that pattern matching of the types of words, the types of tone and vocal inflection, and that leads a human expert to say high empathy versus low empathy. As we think about that just kind of basic example and start to move to the EHR, as we have developed our own generative AI note writing tool, we did a similar process where we engaged some of our customers and said, would you like to partner with us? We first released this in spring of 2022, which I like to note was before everyone was really excited about large language models and GPT things. But again, that idea of providing the AI, here is a recording of a session, and then here's how an expert human summarized it, in what we call a note. And as we give enough examples of that, then the AI begins to learn, oh, here is how humans are summarizing these sessions in terms of either a DAP note or a SOAP note. So at a high level, that process is not only possible, it's happening now at Lyssn and at other organizations. At that kind of much more specific piece of, could it automatically identify demographic characteristics? We could absolutely train it in a very similar fashion to what I've just done, but we're going to have some degree of error. And so like that would be really, honestly, the sticking point is like how accurate does it have to be? If it got someone's gender, race, or ethnicity wrong when it was trying to automatically determine that. And so I think that is, to kind of use that as a potential example, but then pop back up, these AI systems are not perfect. We go through incredible efforts to train them up to high quality, and they're not going to be perfect in every situation. And so we always need to think about how is the human still in the loop, that this is really not about complete and full automation, but it is about the AI providing information to the human so that they can then make the judgment and decide how to use that information.
So, thank you, Dave. The next question, and Ashley, you can probably talk to some of this. You sort of have lots of organizations within your organization, but Dave, you can too. Is a question: what type of organization is Lyssn designed for? Agencies with several users, private practice. It also brings to mind, by the way, some of the interesting types of organizations that are actually partnering with Lyssn. Some of which are not healthcare organizations in the traditional sense. So, any thoughts any of you have on that question?
So, I mean, I can speak to our organization. We are a community mental health center, but we have, like I said, staff working in lots and lots of different kinds of settings. So you have a large variety of training needs. All in the behavioral health space, I would say for the most part. And so, I think there's some similarities there. Centerstone does also operate an FQHC and CCBHCs in a couple of our locations, and so there's a little bit of primary care, which is a little bit different in terms of training needs. We also have I would say in each of our geographic kind of footprints, sometimes you'll find nuances that make them a little different from one another, and that has a lot more to do with kind of the state-specific rules or payer-specific rules. And so we do run into that from time to time, and sometimes it makes a difference in terms of the training need or how you might roll out a particular product. I don't know that has really come up as a barrier for us in terms of how we've implemented the training product. If you think more broadly, about like note taking, for example, there are differences in how we would structure notes. And so there would be, we've had additional work in terms of how we might train the AI specifically around how to Centerstone write its notes. And that means feeding it different examples, to the example that Dave just gave. So it kind of depends on how you're using AI in terms of what problem are you solving with it. But there are differences that are usually for us, they've come up in response to operational realities versus preferences. We usually try to say, let's set the preferences aside. But if there's something that is, really coming up because it's something that it's a kind of a requirement placed on us as an organization, then those are things where we might implement something in a way that might look slightly different from another part of our organization. So I think for the training product, that's been easier in some ways, and that's been more about matching the content to the right service lines and the right clinics to be sure that based on the populations that they serve and the kinds of clinicians that we have at each of those locations, and that could be bachelor's level, master's level, peer support at that level, or it could be thinking more about this is a clinic that primarily works with people that need substance use services or children's services, or kind of more along those lines. So just kind of matching the content to the providers.
Great. And Dave, can you add additional context?
Yeah, so the software at its heart, I think, is very broadly applicable kind of throughout behavioral health care. Where as a business, where we have been kind of partnering and frankly selling is with organizations where they are large enough that they're trying to think about training across many providers. And so that, if you are a provider at Centerstone or an organization, not necessarily that large, but you're thinking about, I want all of my providers who are in our substance use clinic to be at a certain standard of care and offering certain evidence-based practices. Our software directly supports those types of goals and workflows. In some cases, there can be accountability to payers of one kind or another. So increasingly, we are thinking about and seeing examples of value-based contracting, which looks like different things in different parts of the healthcare system. But fundamentally, there's this idea of some of the payment is tied to demonstration of quality, and so within the 988 system, within crisis care, there can be quality assurance that is required if SAMHSA is paying some of those dollars to that organization. And so both at a sort of organizational level, when they're trying to meet a certain standard of care within the organization, as well as these kind of accountability pieces that can be contractual or regulatory. Lyssn has found, Lyssn as a business has found like we're a good match for that. At the moment, we are not selling directly to private practitioners, though that could change at some point in the future.
Yeah, and by that I think you mean like small practices with, say, less than 5.
Yeah, 100%.
And some of the interesting places where I've seen people kind of pull you in, which really fascinate me, and I think we're sort of unpredictable, is, and I'll get to the last question in a second because I think it relates to this, is medication management. in places like primary care and health coaching and probation. And it's kind of remarkable the various places that these skills and trainings and measurement are actually quite relevant. Anything that I didn't mention, Dave, that comes to mind where you've just been like, wow, that's an interesting use case and it makes good sense?
Well, I mean, I think, we all bring our own perspective and in that our biases. And as a clinical psychologist who kind of came up within the clinical psychology trajectories of behavioral healthcare, yeah, I did not realize the kind of the potential applications. And so, yes, kind of throughout health and human services, whether that is kind of frontline child welfare caseworkers. We are also now in the process of working with a 211 call center, kind of the front door for social services, um, and health coaches as well. So coaching is something that is uh, not a traditional licensed health profession, though is increasingly common and popular. And so uh, having good training and good quality assurance of coaches and health coaches is important. And so we are working with a couple different organizations to support their health coaching efforts. We did a webinar earlier this year where we partnered with Togetherall, which is a peer support platform. And again, kind of showing how good conversations that are collaborative, empathic, and goal oriented, um, they show up all over the place throughout, not only just traditional behavioral health care, but really health and human services and kind of health and well-being writ large.
And now going to the other extreme from good conversation, the last question we'll have time for is how specific is AI able to give feedback? And does your AI get down to the core of specific evidence-based practices, or is it more general?
Yeah, so that is a fantastic question, and it is kind of the full spectrum. So we do hit these kind of high level, what we might think of as um, therapeutic alliance, if you're coming from a clinical psychology standpoint of like, can you make a good collaborative connection with this client? But we get very granular as well. So just one example of that is we do have a suite of AI developed specifically for safety risk assessment within crisis care, as well as safety planning. And at that level, the AI is flagging individual statements, either from a caller who is at suicide risk or the call taker who is doing a suicide risk assessment. So we're flagging things like, are you assessing current or past suicidal ideation? Are you assessing plan, means, intent, and so on? And that's at a utterance level. It is, so the AI is tagging individual statements, and you can see that in an interactive dashboard.
Can you talk about, Torrey mentioned CBT, can you talk about a few other of the modalities where you do it both at a high level and a granular level?
Yeah, so within our growing suite of
And note we have a 60 seconds left.
okay, within our growing suite of training programs, all of those are very granular. So it is, you get prompted with a clinical vignette, and then you act as if you were that counselor and you practice that skill. And so that is motivational interviewing, CBT fundamentals. We're just in the process of releasing DBT, multicultural orientation, working with diverse clients is coming up. And I'm forgetting several others. There'll be a number of new trainings coming online.
Great.
And they're all very granular. You do a practice, you get immediate feedback on what you just said.
Well, I want to, any one of you would have been worth spending at least a few hours with. So getting all three of you in some ways limits the value because you didn't all get to talk the whole time, but is actually extra special. And any day I learn anything new is a great day. So this was an extra great day. So thank you for that. Really appreciate you all joining. And it's, of course, great to see you all. So thank you. And thanks to all of you who've joined us as well.
Yeah, thank you everyone for coming, and hope that there'll be opportunity for follow-up conversations, and don't hesitate to reach out on the Lyssn website if you have follow-up questions.
And that's Lyssn is how they spell
.io.
listen.
Yep.
I always forget to tell people, so.